As well as being a Deputy Chief Executive at Manchester City Council, I also provide support for all 10 Greater Manchester Councils through the Association of Greater Manchester Councils on public service reform. And that's where it's not quite 3 million, it's 2.6 million and rising population comes from. I want to say a bit about early years, but I hope in doing so I can just draw out some of the principles that we adhere to in Greater Manchester around public service reform and how they may apply to children's services in general and to the integration of health and social care in general. I think when we think about the reform of public services for children, obviously it's about improving lives, but it's also about economic growth, never more so than in the 0 to 5 years. And I think for Greater Manchester, our two priorities, which are crystal clear for the conurbation of public service reform and economic growth, are two sides of the same coin. And we are absolutely clear that we need to keep hold of the reform side. We'll do quite well, I think, out of the upsurge in the economy, but growth and jobs will not be enough. We have to, in Greater Manchester, do much better than we have been doing in connecting our residents to that growth. And most particularly those residents who are making the most demands on reactive services. So, on the reform side of our priorities, there are two big tickets now. One is health and social care integration, and the other is reducing complex dependency in its various forms. And early years is actually part of both of those. It brings the two together. So, early years for us is reasonably big in scale, nothing on London scale at all, but for us it's quite big, so 2.6 million population and rising. 200,000 of those are between 0 and 5, 38,000 births every year. The really interesting part of that, though, is the total spend for that population, £21 billion every year. But interestingly, it was £21 billion 4 years ago and last year. So despite quite dramatic cuts in spending, total spending has not gone down. And for us in local government, who have lost a third of our budget and a third of our staff, that seems a bit odd, but it's the reality. So for us, early years is quite fundamental, both for growth, but also to actually start to reduce cost of public services because we will need to spend less. So we want to make sure that our fundamental approach to early years actually shows us how the integration of health and social care enables us to ensure that what we know works by way of interventions for 0 to 5s gets delivered in a highly intelligently targeted way at those that most need it. And to do that at such an industrial scale that actually you do have a material impact on total public spending because you are reducing the cost of reactive services. So, all that was on that slide. I'm sure they'll get circulated later. So what do we do about early years? I start by applying the same principles to early years as would to any other cohort in our reform programme. And they are, first of all, choose your interventions on the basis of evidence. I know it's obvious, but we don't do it. Secondly, integrate those interventions with all of the public services into bespoke packages. And thirdly, do that on the basis of families, not individuals or separate problems. And we're applying those principles to reducing the current stock of dependency in Greater Manchester, such as worklessness and families with complex problems. But if we don't at the same time apply the same principles to early years, the strategy will not work because we won't stop the flow of future dependency. And the method by which we apply those principles, very straightforwardly, for any given cohort, in this case 0 to 5-year-olds, co-design a new delivery model with one's partners, and then crucially, model the cost-benefit analysis of that new model versus business as usual, and then start to incrementally deliver the new model so that you start to replace the model data with actual results of fiscal changes in the system. And it's that data that allows partners the confidence and the ability to manage the risk of scaling up. And you keep doing that till you get to the magic point where you start to decommission services because you know what's safe to decommission. That's our method. And we apply that to early years as much as anything else. But we start from a very low base in Greater Manchester. 40% of our children go to school, not raised to learn. So our overall objective is to increase the rate of children go to school ready to learn overall, and at the same time raise the bottom 20% up so the gap closes for them. And the three outcomes we need to achieve that overall objective are health within the family, economic activity in the family, and good parenting. The application of those principles to closing that gap, let me just miss that out because I don't think there's anything there that you won't already know. And let me move on to talk about the application of those principles to closing that gap and achieving those outcomes for 0 to 5-year-olds. We have what I think is a very systematic approach. It's an 8-stage sequence of assessments across the age range of 0 to 5, which we will apply routinely, relentlessly, and at scale, i.e. across the whole of Greater Manchester. And through that, we will engage parents, and where they need it, we will support their parenting and the development of their children. But actually what this does is also give us the information that identifies those who will not achieve those outcomes that I mentioned before. So not just parenting, economic activity in the family and health in the family without intervention. Now we know what works. What this does is give us the intelligence that says, well, who are the 20-25% that actually do need it? And we will therefore, over time, start to take a whole population approach in that way. There are loads of challenges, as you'll appreciate. 2 I'll mention in particular in finishing. First of all, workforce reform, where actually what this requires, if you apply those principles, are firstly integrated working across health, social care and other public services in integrated teams around those individual families that need these interventions. And that has to include a lead worker who is responsible for putting that coordinated bespoke package in place. And I think we're a long way from cracking that. We've got huge amounts more to do on the cultural and attitudinal changes within our public services to make that integrated way of working a reality on the ground. So, for example, we've done a lot to make sure we've got the right supply of health visitors, but getting those health visitors to be part of an integrated team in a neighbourhood is the real challenge. But if we crack that challenge, a lot of the other difficulties like data sharing, I think, become much, much easier. And the final issue I just wanted to raise as a challenge is affordability. This shows that actually if we want to do this, we know that it'll cost around about 20-odd million every year to do this at the full scale. So getting there is quite difficult. At the moment we're spending about 7.6 million per annum on those targeted interventions out of a total spend on the delivery model for early years of about 36 million. So it's a very small proportion. And as we get this right, what this graph shows that the cost will be incurred in the first few years and the payback will come after that. And it also shows that those that make the investment will not be the ones that get the return on that investment in terms of reduced spend on reactive services. I know we all know this, but what we've done with another range of places that have done a lot of work in community budgets to really understand that in depth. We really do understand where the investment goes in and where the return on investment falls and over what period. So what we're going to do over the next year is to pick up from where we are now. We are delivering this model in a trial basis in many parts of Greater Manchester. We're now going to scale up. So in 14-15, we're doing this across the piece. So that during next year, we will generate much stronger evidence as a conurbation, so that in 15-16, we then are in a position to have a very different conversation, not only with local partners like schools who stand to benefit from this, so that we are making sure that those who benefit are contributing, but also with government, because although there are long-term paybacks, there are also shorter-term paybacks. And if we get economic activity right as an outcome, we will have an impact on spend in the benefit system. But that falls not locally, it falls centrally to DWP and the Treasury. And that's the conversation we're going to have with government. They need to see this as something that pays back for them as well as for us. And we need to share the risk and reward with them and do a deal on this. Thank you.
Thank you very much, Jeff. We still have to hear from Ingrid and Maggie, but given I don't want to lose a lot of the great energy and content that Jeff just brought to the conversation. So is there one question from the group that you would like to raise with Jeff? or you can hold it till our final discussion. There you go, Andrew.
Who is it in your system that makes it happen?
Top down, there is leadership from the 10 council leaders at Greater Manchester level, working with the 12 CCG chairs and the acute sector in partnership. So this is part of our health and social care reforms, and it happens at top down across Greater Manchester. And there is, I think, a 20-year history of developing that level of leadership in Greater Manchester. Those relationships, you know, are absolutely essential to making this work. Bottom up, this has to happen at the level of CCGs and neighbourhoods for local government. It has to happen from neighbourhood up, so that you understand in any given locality who are the health visitors, who are the assertive outreach workers for the local authority, how are they going to receive cases from each other, who will they bring into the bespoke packages, what's available in the locality by way of other public services put into those packages. So I think that's where it happens, top down and bottom up at the same time.
Bottom up, is there any one organisation that holds the list of babies and young children?
Yeah, it's a very good question. We do, the council, because we have the data, apart from registration of births, and also by sharing data with our health colleagues. And I think that's part of our wider picture across health and social care, where we need to understand from the point of view of all public services what the population really is, and much as we've heard today, how you segment that, how you understand cohorts, and once you understand your cohorts, you know, in some forensic detail, how that leads you to the right interventions for the right people at the right time.
Thank you, Jeff. I'm just going to hand it over to Ingrid now.
Where is it best for me to stand? Is it over here? I don't want to be in front of the picture. Right, okay. Can you hear me? Yes, even on the camera. Right, thanks very much indeed. Okay, so I'm going to talk about children's health and particularly health services. And as Brendan said, I am a paediatrician by background, so I'm interested in health. But I'm also a public health doctor, so I'm interested in the population, and I'm very much interested in not segmenting the population apart from in age groups. I'm not interested in looking at children at the most high risk. I'm interested in looking at the whole population. I want to shift the population towards a healthier future. So I'm interested in looking at everyday health care. For the bulk of the population. So we're going to start very briefly by just looking at a little bit about the challenge. So this is probably not new to any of you who are interested in child health, but we unfortunately have the highest child mortality rate in Western and Northern Europe by a considerable amount, not higher than Eastern or Southern Europe, but it depends on who you want to be competing with. What that means is that if we compare ourselves with the country that has the lowest child mortality rate, that is Sweden, we have around 1,900 excess deaths in children per year. That is a number of deaths that we wouldn't have if we had the same mortality rate. Now, all of this is not down to healthcare, but a proportion of it is. And because this is in the early years, the scale of loss to society is huge, which is why I get so irritated by the focus is always on the elderly. Not that I resent it, but let's forget about children and young people, because look at the scale of loss from early years, 132,000 person years of life lost because of the difference between us and Sweden. So when we're talking about economic impact for the country, that's huge. So we have to do better. In terms of healthcare modifiable deaths, we think it's of the order of 1 in 5 deaths had some element of modifiability relating to healthcare. So why have we got this wrong model of healthcare, if we think indeed that we do, as I do? One of the reasons is that we have failed to adapt to the epidemiological transition. That is, at the start of the NHS, we had infectious diseases and we had a high need for hospitals and hospital admissions, and we now have non-communicable chronic diseases that require quite a different model of care and a lot of prevention, and we're not really up to speed on it. And not only are we not up to speed on it, we're still investing in this side and not that side. Okay. Right, so priorities. From my point of view, priorities, as I've said, is health. And the message I really want to get across is that the integration needs, and you'll see this is the only time I'm going to use this word, I'm trying to drop it all together because it always makes people think about health and social care, which is fine, but is different for children and young people. So the focus is on health, the reason being that our biggest integration need is on between health and education. That applies to 100% of children. Same with primary and secondary care integration. Health and social care integration is hugely important, but for a small segment of the population. Now, they are costly, but if we're looking at total population burden, it's a small percentage. So if we want to choose where we're going to emphasize to shift the whole population towards a more healthy model, we have to get integration within health right and between health and education right. That's for the whole population. So what's the problem? The problem with the health model is that we have variable and poor outcomes. We have fragmented, inconvenient services, and we fail to maximize our children's potential. The sustainability of the health model is dangerously poor. We have escalating costs, we have increasing demand, we have a workforce crisis in general practice, in pediatrics and nursing, lots of other things that you will all know. Okay, so this is just to re-emphasize this point that is obsessing me night and day, that integration needs are different for children and young people, children on the left, older people on the right. The driver for older people integration is about the dependence and social care. That is what is pushing people to get their act together for integration, but that's different for children. There are different drivers required. It is 2% of the whole population that really depend on social care. And the vast majority of the population might be at risk of it if we don't get our act together, but the problem is different. So I hope that sticks in everybody's mind now. Right. Okay, and not only is the need for integration different, it's different at each stage within early years. So not only are children not small adults, small children are not small children, middle children are not small. So you see what I mean? There's different integration needs, different care needs, different package of care needs required at every different life stage within the early years. So from pre-birth to the early preschool years, there's an integrated health package needed together with early years, together with, well, they're just examples really. The point being that it's complicated within children and young people, let alone that as a whole subset of adults, which is how most people think of it, unfortunately. So it's complex and needs its own special look. So what do we think is needed and what were we trying to do locally? A fundamental redesign of children's healthcare models. We need to be more community focused. We need a huge emphasis on health promotion. We have to reduce the unwarranted variation in quality of care, and we must start focusing better on the broad determinants of health and well-being. And once we get, if we get that coherent health system, that's when we really will be in a better place to interface appropriately with education and then with social care. So we have a big burden, a big task ahead of us. Right, so our program, the Evelina London Child Health Program, is clinically led. It's very population focused, as I said. We're using local, national and international evidence, particularly from Europe. Now, unfortunately, I can't stand here like our American speakers and say what we have done and what we've achieved, because sadly we're at the outset of this, so I hope to be able to come back in some years and tell you it's all worked, but we shall see. Right, so what are we doing? Our aim is to improve child health and well-being, obviously, and we want to do that by building a world-class health system, but very much focused around everyday health care. That's what we're interested in, and we want to root it within a population health research program so that we really learn from children's health services and systems research. Okay, so that's our vision. Not very difficult to figure out from what I've said so far. Safe, everyday health care. We're not focusing on the rare, we're not focusing on the super high needs, we're focusing on everyday health care as a way of shifting the whole population. So what we are proposing, we're at the very early stages of this, what we're proposing is 5 aspects to this model: an acute care hub, a non-acute care hub, supporting primary care better, working more closely between primary and secondary care. I'd like to get rid of those titles altogether, if at all possible, and something we're calling Primary Care Plus, which is something along the lines of the sort of hub and spoke models that's being talked about now in transforming primary care settings. So there are 5 different aspects to this across a community that we are proposing and just starting to work this up. But and the Evelina Academy is about education and training. And this is both for multi-professional education training, but also for families, particularly those with new diagnoses of chronic conditions and so on. And ideally, we'd like to do it together with professionals and families in the same place at the same time. And even more boldly, have GPs, pediatricians, and nurses all in the same place at the same time learning together. Okay, so this is sort of what we're beginning to talk about, an acute care hub. Children's community nursing, which is a vastly underdeveloped resource, we feel. Very much at the center of an acute care provision with GPs and pediatricians working together with child and adolescent psychiatrists right at the front door. That's in an acute care hub. The non-acute is the sort of hub and spoke model that we're talking about, very much dependent on where primary care development goes. Supporting primary care and primary care plus, it's about having locality-based paediatricians, so that the obvious stuff that you think would be sort of basic, like GPs know how to find a paediatrician to talk to and vice versa, we ought to improve upon. At the moment, that doesn't exist. Right, and then the Eveline Academy, as I've said to you, about education and training, both for professionals of all disciplines and for families and young people together. And that's where we hope to be able to deliver the hands-on health promotion that we would like to do as part of our comprehensive health model. Right, challenges and possible solutions. I didn't say enablers. So the challenges are huge, not least financial and cultural. The fact that we have perverse incentives between the most important sort of big providers of care, between primary and secondary care. We are still not aligned in the way that we work together, and finding it increasingly difficult, unfortunately, to do so. The fact that commissioning is split between here, there, and everywhere. Very, very tricky things to get right, and seemingly getting worse. I don't know what you all feel about it, but it certainly is getting increasingly complex to figure out who to talk to about what. So these are some of the possible solutions that we're exploring. I'd be very interested to know if all of you have advice about where we might go with this. We have, these are things that we've learned from European evidence about how co-location can help foster a sense of team and working together, about shared guidelines and practice, but most importantly, that people work better together if they have shared incentives to do so. If they are paid the same way, they belong to the same organization, they care about the same things, and so on and so forth. I'm not quite sure why we find it so difficult to achieve that, but we do. So I'm hoping today is going to be provide the answers to all of these things. So Brendan, if you can provide us with that by the end of the day, we'll be completely delighted. And that's it. I've probably used up more than my 8 minutes.
Thank you, Ingrid.
Okay.
Any questions or advice for Ingrid? Maybe just one before you go to Maggie.
Advice, please. Help. Shall I hand over to Maggie?
Thank you, Ingrid. Good afternoon, colleagues. I'm delighted to be here. Children's Commissioner for England is a child rights-based human rights institute. My doctorate is in education. Doesn't make me a bad person. Okay, my remit will change on the 1st of April so that I become there to promote and protect the rights of the child. If you want a really strong piece of evidence-based international material, the United Nations Convention on the Right of the Child has Article 24 in it, which is about services which are specific to the age group, tailored, not treating them as if they're in a waiting room called "There's a bus coming soon for adulthood," but a population in their own right. And there is a general comment attached to that article. General comments expand on what the article means and talk about what it looks like when children and young people have what the article promises. I was really interested to see that Ingrid's final slide in the diagrams of the hubs talked about children, young people and families as if they actually have agency. There are 12.04 million under 18-year-olds in England, 2011 census. That means they are 1 in 4 of the population. In some London boroughs, Barking and Dagenham, for example, it's much closer to 1 in 3. They are far more numerous than the frail elderly. I'll just say that again. They are far more numerous than the frail elderly. They are as complex. They may not be as dependent, but they are hugely complex human beings. If you ever met a child with a severe mental health difficulty, you will know that. We go in and out of all sorts of settings. My role very particularly looks at children who are most vulnerable, least easy to hear, least easy to reach. So I spend a great deal of my time with young carers, with children in care, with care leavers who are desperately badly let down by all sorts of bits of the system, with those excluded from school, with the disabled, with the very poor, with children and young people who may have a lot of those comorbidities all at work in their lives at once. We owe it to them, really, to get their health services right. In a city this big, with the economies of scale that are granted by London, which sometimes is seen by the rest of the country as thinking there is only London, and sometimes sees itself as if there is only London, whether there are poor children or disabled children or children in difficulty or children in fractured families. You are in a moment of opportunity, it seems to me. There is a Children and Families Bill about to be given royal assent next week, which looks at education, health and care plans for children with special educational needs and disability, which looks at better systems for fostering adoption, post-adoption support, the support of fractured families in shared parenting, which is a public health and community-located approach to wellness, rather than waiting for illness to strike so you have a label to put on something and a treatment to give it. There are around 7.5 million children in our schools in England, and I think they are absolutely the locus for universal provision, as Ingrid's just said, but also for getting in there and integrating the care across the system. There are about 70,000 children in care at any given moment in time, and they are hugely complex, those children. I meet children in care and care leavers almost every day of my working life. Some of them have been taken into care because they've been orphaned or because there is just nobody to take care of them. Some of them are unaccompanied asylum seekers and therefore post-traumatic. And then you meet the child in care who has been pushed from pillar to post, abused emotionally, sexually, physically, in terms of neglect, in terms of starvation, you name it. And you wonder why they are as complex as they are by the time they're 18, and they've been in 17 placements with 25 different foster carers across borough boundaries, and you name it. They're bound not to be very well, it seems to me. And they need our support and they need our help throughout. Last night, about 1,200 under 18-year-olds spent their night behind bars in England. They would have been locked up at about 5:30 yesterday afternoon, and in some young offending settings, they are still given their breakfast pack as the door is locked at tea time. And if you know adolescent boys, you will know that by 9 o'clock last night, they will have eaten it. And they won't have eaten again until about 11:45 today, which is not good for the adolescent brain and is not good for the adolescent emotions, but it happens anyway. There are around 500 under 18-year-olds in secure mental health hospitals. Some are there because they've simply got a very serious mental health condition. Some have a mental health condition overlain with crime. I've met some extremely serious fire setters in secure mental health settings who will always be in prison because they burnt their families to death. And they will move from secure adolescent settings into Broadmoor or Ashfield or Rampton or similar settings when they are 18. There are about 3.5 million children in this country living in poverty, by which I do continue, much as Mr. Duncan Smith would rather I didn't, to remind him that that means you live on less than 2/3 of the median wage for the communities in which you are based. Yes, it means poverty of aspiration and inequalities in health and wider determinants and alcohol and other misuse and all of those other things. But it also means not having enough money coming through the door to make sure you have 2 pairs of shoes, a winter coat, a winter and a summer school uniform, the ability to have your mental health supported by having your friends round for tea because your mum can't feed them. This is serious. It's a serious effect on children's ill-being and well-being. All of them require child-specific, preferably co-designed, co-evaluated services and access to those services. They are not asking for the moon on a stick. The children and young people I meet every day of my working life are asking to be taken seriously as citizens who have agency, can help you to design, commission, provide, decommission and redesign the services that are provided in their communities. They are asking to be taken seriously and to be your partner in all of this. They may well be asking to help you to make the tough decisions that Ingrid was talking about earlier about closing hospital services to move things back into communities where they are a bus ride away rather than a bus and a tube and a walk. It's really important, but I would ask you in your absolutely understandable concentration on this huge and complex city in its many and diverse manifestations, to consider your counterparts in, I don't know, pick a place, rural Herefordshire, where there aren't any buses, and there is only one hospital, and it's 20 bloody miles away, and your GP is not round the corner, and if you don't like him, you can go somewhere else. There is one. And he is quite some distance away, and it's a single-handed practice. And CCGs are scattered entities where people have to drive to get to meeting. I recognise that London is hugely complex, and in some boroughs there are multiple layers of difficulty, and in some of your hospitals and other settings, all of that will be echoed. But the English circumstance is multiply complex because we are such a diverse nation. I am asking everybody in the health economy, and I sit with the Chief Medical Officer sometimes, and I'm on the Health Outcomes Forum for Children and Young People. I'm asking the entire system, really, to see itself as a seamless whole, to go from sub-regional and regional planning to much more local planning through health and wellbeing boards and your partnerships with directors of children's and adult services and directors of public health, as well as providers of acute care, so that what children and young people experience is less of the unevenness of the landscape through which they travel towards adulthood. And I'm asking, finally, that we get in earlier. The Health Select Committee's current inquiry into child and adolescent mental health is an absolute classic. The reason why children end up in adult beds is because there aren't enough child and adolescent mental health beds, and the reason why they end up in those or waiting for one is that we have stripped bare the early intervention child and adolescent mental health services that would have caught them in Year 9 classrooms like mine and sorted them by community intervention at the lowest possible level. So they get sicker and sicker and sicker and sicker and sicker and end up in crisis. If you can do one thing together as a city, it's about moving towards early intervention with your very complex and very varied populations. Thank you very much.
Wow. Okay. So, we've heard about how we're lagging in Western Europe in terms of childhood mortality. We've heard about how there were 1,200 young people behind bars last night, presumably the same team. What can we do, and what challenges do you all face in your communities that maybe our panelists can help you with as well? I think there was a question just here, sorry.
Catherine Duran, for a short period, corporate director in Harrow. Having just spent 4 years building an evidence-based early intervention model in Harrow from beginning to end, based on the foundations, went to Washington State, looked at the cost-benefit analysis, re-stripped everything down, obviously, and tried to make it as coterminous with health. It's going to be a really big challenge to save those services. And beginning to see the care population in teenage years going down, but the care population of under ones going up, which is fine because it is earlier intervention and they're going into adoption. So beginning to see some of the results. But I will say to anybody who's running local authority and CCG, they are going to be stripped to the bone. And they're actually competing with adult services again. And there is not much vision in some of the local politics that's going on, except I hope that in places like Manchester that there will be.
Recognise the frustration and the concern entirely. You're absolutely right. Unless leaders do something, what we know works will not get paid for, delivered. Lives will be worse than they could have been otherwise. No doubt about that. I think we need to do 3 things. Encourage more places to see this as fundamental to the future of their place, economically, socially, physically. In Greater Manchester, we had something called a Greater Manchester Independent Economic Review. It really was independent. It was very hard-hitting. It wasn't actually about the economy alone. It ended up being about early years. You know, people from Goldman Sachs were saying to us, look, if you get your early years right, in 10 years' time, 15, 20 years' time, your economy is going to be starved of the skills it needs. You will hold back economic growth. Get your act together. And that's what we're trying to do. Secondly, I think the reality that public spending is going to keep reducing for at least the next 5 years, on top of what some of us have been through in the last 4 years, as that starts to bite actually to schools, the health service even, certainly the police, all of our partners are being forced to the table with quite a different attitude. They are looking to do the deals because they have to. What we've got to do is make sure that people recognise that the deals around early years are absolutely as essential to them as the more immediate deals around troubled families or criminal justice. And they have to see this isn't just about children in isolation, it's children as part of families. And that's where the cost is being held. And finally, I think, let's make sure we don't just talk to people about this is the delivery model that will save the future. What they have to see is the investment model. We have to get hard-headed about this. It does pay. It doesn't pay back only in 20 years. It pays back within 5 years if you get the right partners to the table and focus on the right things. Getting the parents into the labour market or into better paid jobs is as important as their parenting skills and their health.
I'm Denise Chafffer, I'm Deputy Chief Nurse in London for NHS England. And I suppose I've been reflecting, because I completely agree with what you've been saying, is what are the drivers that we're hearing a lot of the presentations today? And the drivers actually, a lot of them are the hospitals are at breaking point and at crisis and the money's run out, you know. And I think one of the things that I probably say in every arena is 1/3 of the attendances to A&E are children. And I have been in other arenas, particularly in international ones, where they have segmented out that. And I think that might help some of the cost benefit. And so they've looked, for example, about the segment of children that come that aren't health related at all, though they may just be crying babies, parents, the kind of things you've been discussing, the mental health, the self-harm, the 1 in 10 we know that self-harm, alcohol related, I could go on, bronchiolitis, which may be linked to poor housing, damp conditions. So I think there's a way of getting into this which does start to pull out some of the cost benefit, which is quite urgent, which is kind of links with some of the wider stuff. And, you know, I've been trying to find somewhere to kind of get behind that. And I think for your presentation, Ingrid, is particularly about some measurables around that. And I think if we can see some of that change, and that's the same, I'm sure, across the whole of England, you know, we can start to save some money.
I think the gentleman next to you had a comment. Paul Ballett, I'm Commissioner in Merton, South London. I'm really up for early intervention and have been commissioning early intervention services for a lot of years. In the current climate, I do wonder whether we need to differentiate different levels of early intervention and use predictive data much more. I thought the first session this afternoon was really compelling. But I was interested in your phraseology around assertive outreach, which we've been hearing about for quite a lot of years, but I personally don't have a lot of evidence in terms of the impact. So it's about greater targeting, it's about knowing that the people that you need to target are not the people who are going to walk into these early years settings and all that sort of stuff. So any comments about assertive outreach would be interesting. Thanks.
Yeah, I think mea culpa, Manchester, in particular within Greater Manchester, has spent too many decades thinking that you put the right buildings in the right communities, all will be well. And what you end up doing is spending a whole lot of money on 80% of the population that actually are the very people that don't need it, and you ignore the 20% that do need it. And I think the assertive outreach principle is clear to me. You can have all kinds of health visitors who can, if you get it right, identify those who need the assessments, but then somebody has to go in and do the more detailed assessment, and they won't come to you. You have to assertively go to them and make it happen. We cannot sit back. We have to go into those homes, look around the home, understand the circumstances as a whole, and make something happen. That's the only way.
Thank you. I'm conscious that you may also want to get to one more session before the plenary at 5 o'clock. So I think all that's left to say is thank you so much to our panelists for taking the time with all of us this afternoon, and thank you for coming to hear them.